key learning points from Ranjan, and key learning points review will be by Natasha, whereas our dedicated speaker will be Mohammad Disab. Timekeeper will be Indu and Sanskriti. And any question and answer will be answered in chat by Camera and Dr. Krishna. We'll take questions at the end of the session. Any queries can be asked in chat, and that will be answered. I think we are ready to go with this. Today's speaker is our Dr. Ishaq. Dr. Ishaq is fellow in pediatric oncology, pediatric palliative care. He is working in Pain Relief and Palliative Care Society, Hyderabad Center for Palliative Care.
Thank you, Dr. Sunny. Hello, everyone. I am Ishaq, and I have completed my fellowship. So I have joined as a consultant now. So today we'll be talking about neurological conditions as well as neurological symptoms as well as management of those. So next slide, please. So the learning objectives for today is to understand the importance of treating neurological symptoms and to understand the common neurological symptoms and their management. So there are many neurological symptoms which we do come across in our day-to-day life, but one reason for us to identify and to manage these conditions is because the symptom burden can be very high in children with these life-limiting conditions, especially in children with neurodegenerative conditions and impairment of CNS. And these neurological symptoms are difficult in terms of quality of life for the child, as well as they contribute significant distress among parents, families, and healthcare providers. And there are many neurological symptoms that come across, ranging from seizures, agitation, irritability, spasticity, movement disorders such as dystonia, myoclonus, chorea. But today we'll be dealing with these four symptoms. So we'll be dealing with dystonia, agitation and neuroirritability, spasticity, and intractable seizures. Next slide, please. Next slide. Okay, so I start with the case scenario. It's about a 3-year-old girl who's who's with viral meningoencephalitis and is referred to palliative care with episodic body arching and screaming, lasting for 5 to 20 minutes at a time for several times in a day. And during the episode, her whole body arches. She's sweaty, irritable, and cries inconsolably. She has not slept for the last 1 week, and parents are distressed seeing her condition. She is non-verbal and cannot express. Just to for everyone, take a moment and just think about this case scenario, what it can be, and please put it on the chat. What do you think?
Well, while we do this, can I get everyone to mute their microphone?
Yeah. So please put it on the chat. What do you think about this case scenario? Yeah. Next slide, please. So before going into into the symptoms, what I wanted to show you is there are a few objective scales by which we can come to the point where we know that the child is in pain, or to know if there are any distressing features. So one objective scale which we use is FLAG scale. It is an acronym which stands for face, legs, activity, cry, and consolability. It can be used in children who are not communicating with us and who are mentally impaired. There is mental impairment disability, and we can use till 18 years of age. So this is the revised scale. You can see the, I won't go into much detail, but for every item, the maximum score is 2 and minimum is 0. And um, whenever the total score comes as 0, it means that the child is relaxed and comfortable. And when it is 1 to 3, it means mild discomfort. When it is 4 to 6, it is moderate pain. And 7 to 10 means the child is in severe discomfort and pain. So this is how you rate. You can like get this in Google anywhere, and please use this whenever you go and see a child. And the ones in the red are the ones that have been added to the flag scale. Next slide, please. I'm sorry for this slide, but I just wanted to tell you that there is another objective scale, which is for children who are non-communicating, and it is known as non-communicating children's pain checklist. So it has a total of 8 items in it, sorry, 7 items in it, where you just score them, and it is designed for children for use from 3 to 18 years of age who are unable to speak
Navratte.
because of cognitive impairment. And so please mute your mic if you're not speaking. And a total score of 7 or more indicates a child has pain, and the accuracy is around 84%. And whenever a score of 6 or less is there, it means that the child doesn't have pain. So you can see in the below, in the 7th item, eating or sleeping, you can mark the score and you can just get the total. Next slide, please. And this is taken from an article where it shows various sources of hidden pain. So it hasn't mentioned any kind of hip dislocation, fractures. So whenever we see a child who's irritable, who's seem to be in pain, you need to like think about what can be the source of pain from head to toe, whether it is headache, increase in intracranial pressure, whether it is joint pain, muscle contractures, urinary tract infections, pressure source, gastroesophageal reflex. So all those things you need to think about when you are like considering treating or assessing this child. Next slide. So this child, whom we talked about, is suffering from dystonia, and dystonia is an hyperkinetic involuntary movement disorder in which sustained or intermittent contraction of both agonist and antagonist muscles results in repetitive movement. There is twisting and unnatural positioning of the body, as such as in this child, where there was body arching, the child was screaming. So this is a extremely painful condition, and dystonia can lead to difficulty for self-care as well as uh, for the child as well as for the caregivers, and it impacts the daily activity. And classifying dystonia, it can either be a generalized dystonia involving the whole body, or it can be a focal dystonia involving a particular limb or muscle groups. Coming to the next, yeah. So how do we approach? So the first thing is we need to ask ourselves whether it is a dystonia or not. And the elements to consider would be to take a detailed history and physical examination to differentiate dystonia from spasticity and other movement disorder. At times you can find the child uh, having dystonic spasticity as well. So we need to be mindful regarding that. And it is important to investigate further what are the causes of dystonia. And at times we don't know whether it is short dystonia or not. And maybe a trial of treatment in few cases can be given to know whether there is improvement of dystonia. And the provoking factors can be there is whenever dystonia worsens, whenever there is pain, a fever, infection, and whenever the child is agitated also, it can provoke dystonia. And we need to also consider anxiety as well as fear as a provoking factor. And medications, reported medications are selective serotonin reuptake inhibitors, opioids, and methylphenidate. So these are the drugs we need to keep in mind when we are approaching dystonia. Next slide. So going directly into the management part. So how do you manage? One is pharmacological and the other is the surgical line. Pharmacological, the one drug which we use in our practice is trihexyphenidyl. So you start the dose low and you build it up. We don't have so many articles on trihexyphenidyl, but it is a safe drug to use. And uh, the other drugs which we can use is benzodiazepine group. A GABA receptor agonist can be used, as well as dopamine depleting agents can be used. Regarding dopamine responsive dystonia, so this is something that needs to be considered, like when all the other drugs are used up, and the first line which we use is trihexyphenidyl. And neurosurgical, if we want to see, uh, this is not completely, it is an invasive uh, measure, but this is an invasive measure for a palliative care setting. But neurosurgically, what we can do is we can give deep brain stimulation, is what they say, according to the theoretically, if you want to see. Next slide. So in this slide, we can see there are, next slide. So so in the next slide, we can see various drugs and dosages which we can start the children on. So like I said, trihexyphenidyl. Next slide. Trihexyphenidyl, you can initially start with 0.01 mg and you can slowly build it. The side effect profile, if you want to see, with trihexyphenidyl, we can have anticholinergic effects such as dry mouth, blurring vision, constipation, drowsiness, as well as sedation. We need to be mindful about these. And these are the various drugs you can like have a start with. Next slide. So coming to our next case scenario, it is about a 3-year-old girl with post-viral meningoencephalitis sequelae, presenting with inconsolable crying and screaming. She has not slept for 10 days. On examination, there is no obvious or a hidden source of pain, and parents are distressed seeing her condition. And like a previous child, she is non-verbal and she cannot express. So she is the same child who is like having these symptoms of inconsolable crying and screaming. So please put it on chat what you think about it. Next slide. So this child is, sorry, I did not give enough time for answering this. So this child is suffering from, is having agitation and neuroirritability. Agitation is a state of anxiety or nervous excitement, and it is a complex set of symptoms which has psychological symptoms such as anxiety, anger, irritability. It has physical symptoms which includes restlessness, angered speech, disturbed sleep pattern, crying, and autonomic changes as well, which includes tachycardia, tachypnea, and increased blood pressure, as well as diaphoresis. Next slide, please. So how do you approach agitation or neuroirritability? So every symptom which we talk about, we need to have a detailed history and physical examination because it is essential to differentiate whether it is agitation or whether it is some kind of encephalopathy or delirium or psychiatric illness. So one major consideration which we need to put in here is pain. Pain is a key consideration. It can be a nociceptive or neuropathic. And like we told about the hidden sources of pain, all those considerations should be taken in. And systemic symptoms can also lead to agitation in children with neurological impairment. And the provoking factors, just like the previous symptom, it is pain, infection, and anxiety as well. And what are the medications contributing? So the medications that contribute to uh, yeah, the medications that contribute to agitation, it can be uh, medications that are given for other class of treatments as well. So we need to just have a list of what are the medications that are being given, and we need to go back and have a look whether it is leading to any agitation as well. Next slide. So these are, again, I have put this slide to know these are the things we need to consider. Next slide. Next slide, please. So the next slide will tell us about what are the treatment options which we can use. So these are the common medications which we use, with gabapentin being the first line. We use clonidine at our setup, and what we have found out is we start clonidine at a low dose and we slowly build it up over few days. And if clonidine is um, like tolerable to the child, we can like increase the dose immediately. It's not like you need to wait for 2-3 days to increase the dose. Then you have diazepam, midazolam, lorazepam, and haloperidol. I haven't used haloperidol, but for the sake of completion, I'm like mentioning it because few centers would like to use haloperidol. Next slide, please. So this is to just give you an idea of how we can start various medication. So gabapentin, you can start from 3 to 12 years. There are no specific reports whether we can start it prior, but we have used it in a couple of children and it helped them with agitation and neuroirritability. And it is a well tolerated drug. You can slowly increase the dose and you can tite it accordingly. Coming to clonidine. So, clonidine also, like how it is mentioned, you can start with a dose of 2 micro per kg and you can slowly build it up. In India, it is available as 100 microgram tablet. So we just take it and use it in children. Like I said, it can be titrated faster as soon as the child is tolerating it. And then you can use diazepam, midazolam, and lorazepam as well. Next slide. Yeah. So the next symptom which I want to discuss is regarding spasticity and hypertonicity. Spasticity or hypertonicity is an involuntary velocity dependent increased muscle tone. It is commonly seen in children with severe neurological impairment, and it is associated with features of upper motor neuron injury, such as muscle weakness and hyperreflexia. And for assessment, we can use Ashworth scale. It is given in the next slide. Next slide, please. So Ashworth scale, there are two scales right now, and we can use the modified Ashworth scale. It is available on the internet. So you can see that 0 score is for when there is no increase in muscle tone. And as the muscle tone, uh, whenever we see the child in more and more rigidity and increased uh, spasticity, we can score accordingly from 1 to 4, with 5 being the maximum in case of modified Ashworth scale, and 4 being the maximum in case of Ashworth scale. So based on this, you can get to know if there is spasticity or hypertonicity. Next slide, please. So how do you approach spasticity? So again, like previously discussed, uh, we need to see what are the various history and physical examinations, we need to differentiate spasticity from other disorders which increase, like whether it is a sustained muscle tone increase or whether it is intermittent muscle spasm. So we need to differentiate whether it is a baseline increase in muscle tone or an intermittent muscle spasm. And provocating factors, it is the same like the previous ones. So it worsens when there is pain, fever, and infection. Psychological stress and agitation also leads to increased spasticity. So at times, we do take this blood samples for the child, and we do various procedures. So we need to make the child calm before doing it, because in turn, uh, this will provoke spasticity. And regarding medications, specifically, they haven't mentioned specifically regarding medications, but we need to keep in mind what are the different medications that are being used in a child, and then we can take it forward. Next slide, please. So the treatment modality wise, so there is a non-pharmacological way, there is a pharmacological and a neurosurgical and orthopedic intervention. So non-pharmacologically, what you can do is you can do simple gentle massages to just relieve the child. Uh, it should be done by uh, the primary caregivers, and just to relax the child. The other thing which we can do is a gentle physiotherapy, passive stretching of the muscles that are involved after doing massage, so as uh, there is relief and tension in the muscles. And one more thing we need to remember is we need to make them adjusted to their environment, and we can also make them adjusted to activities of daily living by occupational therapy as well. Coming to the pharmacological management, we have uh, diazepam, uh, tizanidine, and we can also use baclofen for pharmacological treatment, and neurosurgical and orthopedic interventions if you want to think about. So these are again a bit of, these are the treatment that are not to be taken in end of life. These are to be planned well ahead. If we feel that muscle lengthening or tendon release will improve the quality of life of a child, we need to go ahead with that. And other treatment is intrathecal baclofen as well as selective dorsal rhizotomy. So these are the various surgical interventions which you can take to relieve spasticity in a child. Next slide, please. So just to show the various dosings of what we can use, diazepam, already the dose has been mentioned in previous slides. You can have a look. And the other medications which we can use is tizanidine and baclofen. We use baclofen in our center. We can also use other benzodiazepines such as lorazepam, which is a longer acting drug. It is a safe drug. You can use that as well, depending on what you have in your setup. Regarding dantrolene, we don't use dantrolene much, but theoretically it is helpful as well. Next slide, please. So coming to our last case scenario, it is about a 8-year-old female child with acute leukemia, referred to pediatric palliative care in view of intractable seizures. Uh, she was having this recurrent right-sided complex partial seizures that were lasting for 15 to 20 minutes with automatism, such as a lip smacking or like blinking of the eyes. She was put on 3 anti-epileptics. She was put on sodium valproate, Levipil, Eptoin, Phenytoin, with minimal relief in her seizure episodes. The parents were anxious looking at their child and wanted to know what can be done. So she was referred to palliative care in view of this intractable seizures, uh, because they were trying all kinds of modalities. And they also started her on um, what do you say, antiviral, thinking that it can be herpes encephalitis. So even with all those things, she wasn't being relieved uh, with seizures. Next slide, please. So what were the possible causes? So Possible causes of intractable seizures, it can be increased ICP, uh, and it can be either hypertension, hypoglycemia, or electrolyte disturbances. It can be stroke. It can be any CNS infection. They were thinking it was a CNS infection. So they got a CSF analysis done as well, which came inconclusive. And it can be because of progression of disease, such as it can be a neurodegenerative disease, cerebral palsy, or CNS malignancy. It can be a brain disease, leukemia, leading to like involvement of brain. And uh, like whatever the various conditions are, we need to take into consideration of various conditions. It can be because treatment modality changes with that. Next slide, please. So how do you treat status? So one of the drug which we used in this child was a benzodiazepine. We started her on a midazolam drip. So we were initially giving her midazolam every 5-minute interval for the initial 2-3 intervals. But when it wasn't coming down, we had to start her on a midazolam drip. We started her on around 1 to 2 mics per kg per minute. And with that, the seizure frequency came down a bit. And if when we are giving benzodiazepines and if still seizures persist for around 15-20 minutes, you can give phenobarbital, whether it is mostly it is IV, since we already secure a line by the time the child has seizures. Next slide, please. So these are the various benzodiazepines which we can use for status epilepticus. So these are the various routes. So midazolam can be given IV and subcutaneous route. It is the same dose, and there is no particular like uh, for a child who's like 30-40 kilos, you can easily give around 3 to 4 mg. And IM route I have written here, it is not commonly used, but if we are not able to secure a line, uh, if you are not even able to give sub-Q, then you can like give IM. But as such, IV or sub-Q route is the safest, and intranasal midazolam can also be used. So it is based on the dosage that is available in your country. So intranasal is also a very good route. And then we have diazepam as well as lorazepam. Lorazepam is a longer acting benzodiazepine. So even this you can use with a duration of 5 minutes interval. But in a general as such, one advantage with lorazepam, instead of midazolam, it has a lower effects of respiratory depression. So that is why lorazepam is much more helpful. Next slide. So this slide is regarding sub-Q midazolam. So sub-Q midazolam infusions can be given when peroral route is no longer uh, available or it is not helpful. So sub-Q midazolam can be given with a quick titration as well. It is same as IV bolus of midazolam. You can give 0.1 mg per kg, and you can also give a continuous infusion based on uh, like the response, and you can just see how to like titrate it or increase it. And yeah, it can also like when we are giving subcutaneous it can help with as an anxiolytic. It can help as a sedating agent and also as a broad spectrum anticonvulsant. Next slide, please. So what are the other strategies which like common management strategies which we use in palliative phase? One is to first of all see what all medications that are going in the child. So this child was on 3 antiepileptics. So after starting on midazolam, we came down to 2. We stopped Eptoin in this child. So see what medications will be best helpful in a particular child. So it should be case based. And the next thing is it'll be better if you can use broader spectrum with additional desirable effects such as what we told, benzodiazepines are a broad spectrum anticonvulsants that can be used. And one more thing, what you need to see is, are there any provoking factors? So if there is any, what do you say, component of anxiety or pain, it is better if we also start medication to look into treating neuropathic pain or anxiety. And at times when the child is having this intractable seizures continuously, which is affecting her quality of life, one thing what you can do is you can provide some good sedation so as to like have both the uh, seizure control as well as for any other symptom management. So you can like go for like this mild sedation as well with midazolam infusion. Next slide, please. So what are the other things which you can use apart from anticonvulsants? One can be antibiotics. In her, we started her on IV acyclovir, um, which did not help much. But as such, if it is a case of herpes encephalitis, it will be helpful if you're giving antibiotics. If it is a meningitis case, it'll be better if you can go with a broad spectrum antibiotic as well. Then radiation is one thing which you can do, chemotherapy, steroids. Then there is correction of metabolic derangements. Surgery for tumors, this is something again invasive. This is something we need to think when the benefit outweighs the risk. And one more thing is immune reconstitution syndrome. It is common in AIDS after starting of retroviral therapy. So in that case, it will be helpful if we start treatment with steroids. So these are the various ways how you can like take care of intractable seizures. Thank you.
Thank you, Dr. Isaac, for such a wonderful and elaborate presentation. Who will take questions after the case presentation? Dr. Hema, are you ready?
Yes, I'm ready.
Thank you. Dr. Hema is MD Pediatrics working at Pediatric Department in Kanti Children's Hospital. Please, Dr. Hema, go ahead with your presentation.
Good morning, everyone. Today I'm starting with my case presentation. The key questions for my case presentations are assessment of neurological symptoms and their management, counseling and supportive care for parents and child with seizure, and multidisciplinary approach for management. Our case, 9 years old female who was diagnosed with B-cell precursor acute lymphoblastic leukemia, B-cell ALL Kala positive on 2018 November 2nd with seizure, and we were suspecting CNS relapse. Regarding significant investigation, the bone marrow aspiration showed B-cell lymphoblastic leukemia with flow cytometry showing B-cell precursor acute lymphoblastic leukemia, Kala positive. BCR AVL gene rearrangement was positive, and the child was currently under third cycle of maintenance therapy. The investigations showed hemoglobin of 12.1 gram per deciliter. Total WBC count was 8,800 with absolute neutrophil count 6,688. Platelets was 2,22,000. The peripheral blood smear showed no atypical cells or blast cells, and other biochemical investigations were normal. The CT scan of head, both plain and contrast, showed normal findings, and the lumbar puncture was not done yet due to poor general condition. Regarding pain and symptoms, including relevant treatments, during maintenance therapy, presented with abnormal body movement and loss of consciousness, one episode lasting for 10 minutes. She had altered sensorium for 1 day. She was admitted to PICU. She was disoriented. Eye opening was on painful stimuli only, produced incomprehensible sound and unable to feed herself. So she was kept on NPO and IV drip was given. 2-hourly position changing was advised. Suctioning of oral secretions were done as per need. NG was planned, but parents were reluctant for NG fitting. Catheterization was also not done and diapers were used. After 2 days, she was shifted to ward. She was able to feed some liquid by herself without aspiration on 4th day of admission. On 6th day of admission, she was able to take solid foods, recognized parents, and able to sit with support and speak few words. Power was 4 by 5 on all limbs and planned for physiotherapy, so consultation was done. Regarding past history, there was no history of seizure in the past and no family history of seizure. She was given antibiotics with injectable cefepime, then injectable meropenem and injectable vancomycin. For seizure management, seizure was controlled with intravenous diazepam and loading dose of intravenous levetiracetam was also given. Other continuous treatment were injection dexamethasone at the rate of 0.6 mg per kg per day, 6 hourly, injection 20% mannitol at the dose of 0.5 gram per kg 6 hourly, and injection levetiracetam at 40 mg per kg per day, and injection diazepam 0.2 mg per kg when required. The neurological consultation was done and was planned for EEG. Regarding psychosocial and family concerns, she was from a nuclear family. Her mother was a homemaker, the father was farmer. There was a loss of job, source of income as they had to stay with the child, and the parents were worried regarding management and were concerned about treatment options and probability of cure. Regarding spiritual concerns, they follow Hinduism, strong religious devotion of family and the child, and they consider that current condition was due to the wrath of God. The child had poor general conditions and disoriented. The parents are concerned about improvement and possibilities of recurrence of seizure, communication regarding possibility of seizure recurrence and CNS relapse. Regarding collaboration and partnerships, she was consulted with the dietitian with dietary consultation. Psychosocial counseling with expert psychologist was done. Neurological consultation and regular review was being done, and they are using reserve fund for treating children. Now, the summary of the case. A 9-year-old female child on the 3rd cycle maintenance chemotherapy for B-cell precursor ALL had 1 episode of seizure with disorientation. The CT scan of head showed normal findings. The parents are worried for the management and probability for cure or recurrence of seizure. Curative along with palliative care was started. Now, the key questions for case presentation today are how to manage the child with seizure and other neurological conditions, how to counsel when parents are worried about seizure, but there is even greater possibility of CNS relapse, and what other supportive care could have been provided in such scenario. Thank you.
Thank you, Dr. Hema, for such a nice presentation. Any thoughts from any faculties regarding the case? Megan, would you like to say something on the case?
Yeah, it was an interesting case, and I think it's a common situation that we face where we're not quite sure. It sounds like why the patient had like the sort of acute episode, but I think just as a general supportive approach is often what we go for in these situations where we just see how the child improves, you know, hoping for the best. And I presume that from an oncological standpoint, you would. I know you haven't done the LP yet, but you probably are interested to do the LP to see if there's CNS involvement going forward. But I'm not an oncologist, so I'd be interested in comments on that point.
Thank you, Megan. Dr. Sudhir, would you like to add anything?
Yeah, there are a few issues in this case, like regarding the supportive care. We had tried to keep the NG feeding, and so the patients were reluctant for the NG feeding. And also there is another issue regarding the use of the catheter in each case with the seizure disorder. And apart from that, we had done good with the position changing and providing the physiotherapy. Maybe Dr. Ishaq, would you like to discuss about the possibility of NG feeding in this child with seizure and the use of the catheterization in each case with seizure, because the parents were reluctant?
Yeah. So regarding NG feeding in this child, see, what I felt was it depends on what our goals of care are. Again, if NG feeding is going to be helpful in the child, because whenever there's seizure episodes, we don't want the child to be stomach full. That's what we tell to our patients. If the child is having seizures, we tend to like keep the child, hold the child on any oral feeds, whether it is orally or via NG. So if the child is having seizure episodes, I would be much more cautious regarding the feeding. And once the seizure control is got, then we can slowly start on guarded feeding. Either it can be with the OG tube or it can be with the oral as well. So initially how we can start with oral liquids, then we can slowly go with semi-solids in that way. Regarding catheterization, again, if you are catheterizing, you mean to say like urinary catheterization, right? So whenever we are going with catheterization, we need to know why are we catheterizing the child in first place. Do we want to know, do we want to have a strict input-output charting for the child? If that is the case, maybe catheterizing would be helpful, but it would be only for the time being. It shouldn't be like for the prolonged catheterization of the child. Catheterization, we tend to go only if the child is having any kind of spinal cord compression because of incomplete voiding. So we tend to catheterize in those situations. But as such, if you're asking me regarding catheterization, it'll be better if we catheterize if we only want to know a strict input-output amount of liquid. So any other thoughts regarding these from other faculty to be helpful?
Yeah, maybe Peter, do you like to add something?
Yes. I think we need to look to see whether we're treating a reversible cause or a not reversible cause. So if, for example, we found that there was significant increased ICP or bleed in the brain, and that the seizures are going to be very difficult to manage, and level of consciousness may be difficult to restore, then that's a different discussion. In this case, it sounds like it was a reversible cause. So I think the NG tube was not as critical because you could maintain her on some IV fluids until you manage the seizures. And of course, when she's sedated with the seizure management or from seizures, it's not safe to feed either orally or sometimes through the NG tube anyway. So it might be possible for a short term to maintain with IV fluids until getting her more stable. And I would say the same thing with the catheter. I think if it's temporary, then and you're able to get by, and I'm not sure how what supplies you have in terms of maintaining hygiene without a catheter when she's level of consciousness is decreased. If that is possible, then that would be preferable as opposed to putting in a catheter in the shorter term because of the risk of UTI as well.
Yeah, definitely. We have to individualize the case, and depending upon the scenario, we can decide on that. And on the same case, we had a second question: how to counsel when parents are worried about seizure. They are worried that there might be recurrence of the seizure, but there is even greater bad news that there might have been a CNS relapse, because seizure would be more treatable than the CNS relapse. So I'd like to go to Kamara. Because they are worried more about the seizure, but we are worried more about the relapse. How to effectively communicate in such situation?
Thank you. What an excellent case and so well presented. And I think just brings to mind that we see a lot of symptoms, and sometimes we think, you know, they're kind of every day and we see them and we manage them. But for a parent who has seen a seizure in their child or their child acting differently, it is one of the most scary things. And I think the first piece is for staff to say to families, to acknowledge that their child is acting very differently and a seizure is a scary event. I would then move to asking them what they think is the cause of the seizure, why they think she's behaving the way she is, because they might have a very good understanding that it's treatable or it's going to be helped, or it might be the cancer, and they have a wide breadth of understanding, or they might not. And so parents need to be understood in what their worries are and what their concerns are. Obviously you guys are still waiting. I see that the reports are waiting from the LP. So keeping parents up to date with why you're doing the tests and what you're looking for, what you're worried about, and what you're hoping for. So you're hoping there isn't cancer cells, or you're hoping there isn't a bleed, or you're hoping that this is a one-time thing and she'll recover. But if you have big worries about her, you have to share that with parents along with the plans. So we're going to start her on an anti-seizure. We're going to do this, and we're going to anticipate that she might have another one, and we have a plan for how to manage. I'll stop there, but I appreciate so much the question around the psychological impact on the parents and the child in having such a difficult symptom. Thank you.
Yeah, thank you, Kamra, for that. And Dr. Krishna Sagar, would you like to add something?
Thank you for very good, nice presentation of both speakers. We do convert most of the time of the leukemia and CNS metastasis child with the similar condition, and we always worried about whether we have to start fluids. Parents are reluctant, both catheterization for NG tubing, so sometimes nutrition sees some of the questions. And even we tried our best with the most of the antiepileptics available here, we do come across some of the repeated seizures, retractable seizure as well. So sometimes very difficult to manage such. Levetiracetam and sometimes it's not much working high. Even that also we do get the retractable seizure, and we do use maybe repeated midazolam sometime, but sometimes it doesn't help. Sometimes we don't have much answer how to control it all. So even after the few days, still they do have the some type of seizure. So very difficult the scenario. Sometimes we get it. So maybe faculty can put something like that. Dr. Prakash Paudel, Professor Dharan also is a pediatric neurologist. Maybe he can put some lights on it if he's here, and maybe other things. Sometimes very difficult. Even we tried all, but still, even that there is no CT and MRI shows no intercanal bleed, CSF is within normal, and we cannot find out exactly cause. And then parents are quite worried, and even we are too worried. We do not control it that. So that is a very typical situation we came across most of the time.
Yeah, Dr. Prakash.
Yes.
In the forum.
Okay. So good morning, everyone. So first, I would like to start with counseling. I would like to add one point. So seizure, as Megan said, it looks very scary, and often the parents usually think that their child might die due to seizure because it looks like that. So during counseling, we should ensure that seizure per se is not going to kill the child, because this is very unusual. So if seizure is happening in front of us or in front of someone there is attendant, so we should ensure them that seizure per se is not going to kill their child, because that is the most important worry the parents have. Then regarding intractability of the seizure, okay, so for counseling, we should also teach them that how to keep their child safe during seizure, because their thinking are very vague. Sometimes they keep finger inside the mouth. They try to give something, give water, offer water to child during seizure. We should ask them to put child in safe position, in lateral position during the seizure, and within few minutes it will subside. And if not, we are going to give medicine that is going to stop seizure. We have to counsel like them. Regarding intractability of seizure, yes, some of the seizures are really very intractable, and management of intractable seizure is quite challenging. So in BPKHS, what we do is we keep the patient, we try 2 or 3 anti-epileptic, and if they are not working, we are not going to use 4, 5, 6 anti-epileptic. We start with midazolam infusion, and we titrate it up. We keep the patient in ventilator, and we titrate it up, and we can go up to 20, 24, 25, sometimes 30 microgram per kg per minute. And with that, in most of the cases, we can control seizure at least transiently. For long-term control of intractable seizure, it is quite challenging, and only one medicine or one approach is not going to work. So we should try one approach, and if it fails, then we should try another approach. Thank you.
Thank you, Dr. Prakash Powder. And regarding the same case and to share his experience, I'd like to ask Dr. Vishnu Giri. He is the pediatric hemato-oncologist at Kanti Children's Hospital. Would you like to add something about the case or your experience regarding similar neurological cases at Kanti Children's Hospital? Would you, Dr. Vishnu Giri?
Thank you, Dr. Sudesh. Regarding this particular patient, it's improving now. The GCS has improved, and after some level of improvement in the GCS and her activities, we performed lumbar puncture, and we are awaiting the report. This CNS relapse is a possibility in this patient because this patient has BCR-ABL positivity, and she was on tyrosine kinase inhibitors, which was not being taken regularly for various reasons. So relapse is a possibility. We are still waiting for the reports, although CT scan is normal. Apart from that, in seizures on patients on chemotherapy, in our center, we prefer to use levetiracetam, mainly because we want to avoid drug interactions with the conventional, the anti-epileptics that are in use since quite long. And for short-term control, as mentioned, the benzodiazepines are used as and when necessary, and we mostly stick to levetiracetam itself. Thank you.
Thank you, Dr. Vishnu Giri. Any participants would like to share their experience, or if they have any query regarding the presentation with Dr. Ishaq or any other faculties, please you can unmute yourself and put forward your question. We have lots of pediatricians from outside of Kathmandu Valley also. Maybe Dr. Damodar, would you like to share your experience? What are the clinical difficulties and the difficulties in communication in such neurological scenarios in the periphery setting?
Yeah, most of the time we used to come across the seizure status epilepticus form, and sometimes we are very difficult to find the medicine, as well as the availability of medicine is not so good in our setup. So whatever we found, like after counseling, we used some benzodiazepine firstly, then phenobarbital like other medicine, and the availability of the anti-epileptic drug is very short in our center. So we face difficulties to control the seizure, and the availability of PICU setup is also very lagging in our center. So we face difficulties to manage this type of case in our center.
Thank you, Dr. Damodar. Definitely, managing is one of the challenging aspects, and even challenging is the availability of the resources at the working center. And many of times we discuss the treatment options, but the options are not actually available in our setting. I would like to ask now.
Can I have a
Yes,
question?
Dr. Krishna, please go ahead.
This is most of the time from us, from the doctor side. Have any nursing
Yeah.
here we can have the experience, how they do it, how they feel? Someone can share it, one question. And just like EEG, sometimes we do not have the EEG at all time in all hospitals, and sometimes we think it could be more helpful to control it, some signaling, but I do not have in my own center. So sometimes I could not, if I like also, I could not refer for the EEG. So does EEG have some clue to manage the such intractable seizures? And some nursing, anybody can share their experience, either Kanti from Bharatpur or anywhere, so we can know from how they feel it.
Bandana sister, are you there? Himal Soba sister. Himal Soba sister, are you there?
Maybe Parvati sister, Rita sister, anybody can, maybe how do you feel and what's your experience?
Because whenever there is a seizure and parents are there, so the doctors may not be available 24 hours. So the nursing staffs are the first one to tackle this situation. So what are the issues in communication while there is seizure, even after the seizure has resolved? So would Angela sister, would you like to add something to that? Share your experience.
I can speak if.
Yeah, sure.
For those of you who don't know me, I'm Melanie. I'm one of the nurses. I'm from Vancouver. I work at Canuck Place Children's Hospice and BC Children's Hospital in oncology and palliative care. And for me, I witnessed a lot of seizures in my career so far and supported parents through them. I think one of the biggest things as a bedside nurse during seizures is to maintain a calm presence with the family, kind of walking them through it, talking to the patient, making sure if there's secretions or anything like that, you're wiping those away and getting them into a comfortable position, and kind of guiding parents with what they can do, which is just comforting their child during a very scary, difficult thing. I think that's the best thing you can do. And also keeping in mind that you're walking through the family with the steps that you're taking as well. Like you can communicate what you're seeing, they still look pink, they're breathing well. If it's been 3 minutes, at this point, we'll give some medicine. We're going to call the doctor soon. Just kind of maintaining that communication and calm presence and doing whatever you can to make sure their child's comfortable. And
Thank you for sharing your experience. Definitely, we have to be calm ourselves before we make the parents. So that is one of the good points you have made.
Dr. Sudhir?
Yeah, Dr. Prakash.
Yeah, so may I answer the question regarding EEG, because this is very important
issue
Dr. Krishna Sagar raised.
Yeah, please. So, we're running out of time. Please be precise.
Okay, I will quickly answer this question. So for management of status epilepticus, EEG does not have much role because there is standard protocol for management of status epilepticus, and we can follow that protocol. Basically, EEG for correct diagnosis of type of seizure and long-term management of seizure. Only rarely, for example, sometimes we treat the patient and patient is non-communicating, patient might be in ventilator, having non-convulsive seizure. In that case, if you want to know whether patient responded to our medicine or not, in that rare situation, we can do bedside EEG and see if seizure is really controlled from inside. Otherwise, for most of the scenario, most of the times, for management of status epilepticus, EEG does not have much role. Thank you.
Thank you, Dr. Prakash. Definitely, we are going for the symptom management while focusing on the palliative care. We are going for the symptom management and the disease itself. And we know that EEG is not readily available in most of these settings, and it's not done on emergency basis also. So we should not give priority to EEG and perform it whenever it is available on the later time period. Definitely. Any other views from the participants? We'll be taking the last participant if you would like to share your experience. Any nursing staff from Kanti Children's Hospital or BPK KMCH Chitwan? Okay, any final thoughts from the faculties? Would you like to add something that we are discussing, or would you like to add some more points to that, to the part that we have already discussed? I think it was a camera. Are you? Yeah.
I would just say I'm hoping that for the case that the child recovers. I think if not, the escalating and the support of having the medications and escalating care is available, and sounds like there's a lot of expertise around this child, and I think reaching out to this group if more questions need to be answered is also very available to the team supporting them. So good luck, and I hope the care goes well.
Thank you, Kamra. Definitely the discussion that we are doing here is to be reflected on the child's care. That is the motto of this session. And if we don't have any question, maybe Dr. Sunny would like to end today's session.
Thank you, Dr. Sudhir, for facilitating all this through. If there are any more queries, we can always consider in chat and mails. We'll be communicating through the mails and WhatsApp. Thank you for today's participant. We'll end this session now. Thank you.
Okay, bye everyone.
Thank you. Bye-bye.
Bye. Thank you.